Hello all. Continuing with the vertical integration sessions. Today is the sixth edition of the vertical integration sessions focused on the MBBS students. Today the topic of discussion is something of great clinical and academic importance, that is diabetes mellitus. To take this session forward, we have eminent faculty from various departments. I'll introduce the panelists for the day. We have Dr. Rena, who is assistant professor in the Department of Ophthalmology. Dr. Suja Madam from the Department of Physiology, Dr. Sumitra Unni from Biochemistry, she's an associate professor, and Dr. Anup Menod, assistant professor from the Department of General Medicine. We will be following the same pattern today also. That will be that we'll be asking subject-specific questions to each of the panelists, and we will end with important questions from the subject. To start with, I will start with physiology. Madam, can you describe the physiology of insulin secretion to start with?
Okay, so insulin being a peptide hormone, it is stored inside the pancreatic beta cells, and so it's stored in secretory vesicles. And the most important stimulus for release of insulin from the pancreatic beta cell is glucose. So when blood glucose level goes above 100 milligram per deciliter, that is the time when insulin starts secreted from the pancreatic beta cells, and when it goes below 60 milligram per deciliter, insulin secretion stops. Now, glucose usually gets elevated after a meal. So post-prandial, when the blood glucose level gets elevated, glucose enters the pancreatic beta cells through GLUT2 receptors. We'll be discussing about that later, I suppose. So once glucose enters the pancreatic beta cells, it undergoes glycolysis, and ATP produced as a result of glycolysis, it closes or it inhibits an ATP-sensitive potassium channel that is present in the pancreatic beta cells. So once these channels get closed, potassium efflux is inhibited. So potassium accumulates inside the pancreatic beta cells, resulting in depolarization of the pancreatic beta cells. Okay. As a result, voltage-gated calcium channels open, and there is calcium influx into the pancreatic beta cells. Once the calcium concentration inside these beta cells increases, it results in exocytosis of the secretory vesicles, releasing insulin into the circulation. So in response to the glucose, we see a biphasic response of insulin secretion. So initially you get a peak of insulin secretion within a few seconds of an elevation in blood glucose level. This lasts for a few minutes, following which you get a second peak, which is seen about 5 to 10 minutes after the first peak. And the second peak lasts for a longer time. The initial peak is because of release of pre-synthesized or pre-stored insulin already in the pancreatic beta cells, and the second peak is because of newly synthesized insulin that is released into the circulation. So we call it as a biphasic response. Now, apart from glucose, there are other factors that can also stimulate insulin secretion, one of them being amino acids like lysine and arginine, and then you have sympathetic stimulation, which acts via alpha and beta receptors. So alpha receptors, they inhibit insulin secretion, and that is what we see during exercise when there is or any type of stress which causes increased sympathetic activity. Acting through alpha receptors, they inhibit insulin secretion so that the blood glucose level does not go down. And parasympathetics, acting via the acetylcholine, they increase or they stimulate insulin secretion. Okay. And so these are few factors that can stimulate insulin secretion.
Okay. Since we got some basic understanding regarding the insulin production, Doctor, can you kind of enlighten us on the pathways of glucose production?
So any metabolic pathway, whether it has to be activated or inhibited, it depends on a person's fed state, fasting state, or pathological state. So soon after a person consumes food, that is what we describe as fed state, the blood glucose will be absorbed from the intestine, and it will be stored in the liver as glycogen and in the adipose tissue as fatty acids, if the body doesn't have any immediate needs. If there is some immediate need, it will be immediately utilized. Now after this, after around 2 to 2.5 hours of food, what happens is the blood glucose level starts coming down. And then after this period, for about 8 to 10 hours, the hepatic glycogenolysis begins. That is breakdown of glycogen to form glucose molecules. After glycogenolysis, gluconeogenesis sets in. Then after about 18 hours, which is described as the starvation period, the lipolysis happens where the body depends on the fat for its energy needs. So basically, during the initial fasting period, glycogenolysis and gluconeogenesis they are the ones who are managing the whole thing. So ultimately, the body's aim is to maintain the blood glucose level at any cost.
Okay.
Now about glycogenolysis, it is a breakdown of glycogen molecule. So glycogen is a homopolysaccharide that is the storage form of carbohydrates, and it is stored both in the muscle and the liver. Now the liver glycogen content is actually more, but when we check the overall glycogen quantity, it will be more in the muscle because of the increased body surface area. Now glycogen, the hormones that help in glycogenolysis are mainly glucagon and glucocorticoids. Then we have the gluconeogenesis. Gluconeogenesis, it's the definition is the synthesis of new glucose molecules from non-carbohydrate precursors. And these non-carbohydrate precursors are lactate, glucogenic amino acids like alanine, propionyl-CoA, the glycerol part of fat, etc. So the gluconeogenesis is also under the hormonal control, and that is stimulated or activated by glucagon.
Okay. Now, that is with the production. If you can just elaborate on the metabolism part and what role it plays in the body.
Okay. Yeah. So the main metabolic pathway of glucose is the glycolysis, glycogenolysis, glycogen synthesis, gluconeogenesis. Yeah. Apart from this, we have minor metabolic pathways also.
Okay.
So the main metabolic pathways have already discussed glycogenolysis and gluconeogenesis. Yeah. So now we'll see about glycolysis and glycogen synthesis. Right. So glycolysis takes place in almost all the cells. It can happen under aerobic and anaerobic conditions. So under aerobic conditions, the glucose is first converted to pyruvate and then into acetyl-CoA by the enzyme pyruvate dehydrogenase, and this will give us 7 ATPs. Now we have the anaerobic condition. Here, after being converted to pyruvate, the glucose is converted to lactate. Now, why this is happening? Why is the glucose being converted into lactate? That is because the step 5 of glycolysis, NAD is converted to NADH. Now, this NAD has to be brought back so that the pathways can happen in a smooth manner. For that, these two pathways are coupled together. That is, the NADH is utilized by the lactate dehydrogenase enzyme, and you get NAD. That NAD is then coupled with the step 5, and this whole cycle takes place without any hitches. And then we have glycogen synthesis. Glycogen synthesis, the synthesis of glycogen from glucose molecules. And both these pathways are activated by insulin. Then I spoke about the minor metabolic pathways. Yeah. Mainly we have Cori cycle. Cori cycle is or lactic acid cycle. Now this is like in actively contracting muscles, lactate is produced from glucose. Now this lactate, if it's accumulating in the muscle, it can cause muscle cramps. So this lactate will enter the blood, then it will enter the liver, where it is oxidized to pyruvate. And this pyruvate is channeled for gluconeogenesis. Okay. And then once this glucose is formed, it will re-enter the muscle. And again, it is converted to lactate. That's why it's called a cycle. Yeah. Then we have another minor metabolic pathway, that is the Rappaport-Lubering cycle or the BPG shunt. Okay. Here in the step of one of the steps of glycolysis, the 1,3-BPG is converted to 2,3-bisphosphoglycerate or 2,3-BPG. Now this 2,3-BPG will bind to hemoglobin, and the affinity of hemoglobin to oxygen is reduced. So the result is that there will be more unloading of oxygen to the tissues. And this is utilized in high altitude conditions and also in fetal circulation. Then we have another important minor metabolic pathway, that is the HMP shunt pathway or pentose phosphate pathway. Now HMP shunt pathway has two phases, oxidative phase and non-oxidative phase. This oxidative phase takes place in tissues like liver, adipose tissue, mammary glands, testes, ovaries, RBCs, lens of the eye. And we get NADPH, which is a reducing equivalent out of this oxidative pathway. Now, this NADPH is utilized for lipid and steroid synthesis. So, when we trace to lipid metabolism, we can see that cholesterol synthesis and fatty acid synthesis also takes place in these organs. So, the NADPH that is produced by the HMP shunt pathway is utilized for this productive biosynthesis. Then we have the non-oxidative pathway. Non-oxidative pathway takes place in almost all the cells, and it is mainly for producing ribose, which is used for nucleic acid synthesis. Then there's one more minor metabolic pathway, that is the glucuronic acid pathway, where UDP glucuronic acid is produced. This is utilized for conjugation of bilirubin, steroids, drugs, and also for synthesis of glycosaminoglycans.
Okay. Dr. Suja, continuing from where we stopped, if you can elaborate on the GLUT receptors.
Yeah. So most of the tissues in our body, they are dependent on insulin for the entry of glucose into the tissues. Okay. Except there are some exceptions like RBCs, brain cells, you have liver cells, pancreatic beta cells, which are not dependent on insulin. Now, glucose enters the tissues mainly via facilitated diffusion, where they make use of this GLUT transporters. And you also have entry of glucose into the tissues via secondary active transport mechanism, where they make use of sodium glucose co-transporters. Okay. Now, this SGLT, they are found mainly in the renal tubules and the intestine. So there are two types, SGLT1 and SGLT2. SGLT1 is mainly seen in the small intestine, and SGLT2 is seen in the renal tubular epithelium. Okay. The next group of transporters involved in glucose transport are the GLUT transporters, and you have 7 types, GLUT1 to GLUT7. Yeah. GLUT1 and GLUT3 are involved in basal glucose uptake, and they are seen in the blood-brain barrier, placenta, the intestine, etc. Mm-hmm. GLUT2 are the ones which are seen in liver, pancreatic beta cells, which are independent of insulin. They are already present on the cell membrane, and glucose enters into the tissues through these GLUT2 transporters. They are also seen in the basolateral membrane of renal tubular epithelial cells and intestine, where once they enter the cell through SGLT1, they move out into the interstitium through GLUT2 transporters. Then you have GLUT4, which are insulin-dependent glucose transporters. So these are present in vesicles inside the target tissues, and they get inserted onto the cell membrane only when insulin binds to the insulin receptor. So that's why we say they are insulin-dependent glucose transporters. And they are mainly found in the skeletal muscle, cardiac muscle, adipose tissue, and other target tissues. Then you have GLUT5, which is actually involved in transportation of fructose, which is seen in jejunum, etc. Then you have GLUT6. The exact function of this transporter is not known. It is found in spleen and other tissues. And then you have GLUT7, which is involved in transport of glucose 6-phosphate into the sarcoplasmic reticulum, which is found in the liver. So these are the main glucose transporters. And one thing that we see is, and the mechanism exactly not explained, is during exercise, there is some mechanism that inserts GLUT4 transporters onto the cell membrane even without the help of insulin. And that is why we say or we advise patients with diabetes mellitus in the initial stages to do exercise. So even in the absence of insulin, it causes insertion of these GLUT4 transporters onto the cell membrane and help to bring down the blood glucose level.
Okay, right. Anup, first question to you. When do you call a person diabetic, and what do the latest guidelines and definitions tell us?
Thank you, sir. So, there are so many ways in which diabetes can actually be defined. So, one is taking a depth from all of these faculty. It can be defined as a lot of abnormal physiological processes that results in a common phenotype of hyperglycemia. Like for example, diabetes is defined by an absolute or relative insulinopenia, and insulin, as we all know, is an anabolic hormone. So diabetes is very closely related to this entity which is called metabolic syndrome. So for a normal glucose load, or for the same glucose load, the Indian population or Asian Indian phenotype has a tendency to deposit fat around the abdomen when compared to an overall fat distribution for the Western world. So now why the fat in the abdomen is more dangerous? That is the exact reason why BMI is considered overweight, more than 23 in Indian population, and in the Western world it's more than 25. It's all related to the fat in the abdomen. Now, as the moment the patient reaches a pre-diabetic state, there is HbA1c of 5.7, there is a lot of changes that is happening in the adipose tissue, like alpha receptors getting converted to beta 3 receptors. And insulin being an anabolic hormone, when there is insulin resistance, there starts catabolism. So your adipose tissue, the fats are broken down into free fatty acid, and the proteins are broken down into amino acid. Just the opposite of what usually should happen. And that will, because the adipose tissue in the abdomen is very close to the portal circulation, it will go to the portal circulation and it will get converted. So insulin keeps check on the hormone called hormone sensitive lipase. So insulin deficiency causes abnormal activation of hormone sensitive lipase, and that causes the free fatty acid to get converted into a molecule called fatty acyl coenzyme A. So I wouldn't define just diabetes as a common phenotype of hyperglycemia, because the macrovascular complication especially is linked to metabolic syndrome more than diabetes. So the term called pre-diabetes is also very important. Another way of defining diabetes is that it's a disease of the blood vessels. Because why we want to keep the blood glucose under control? We want to control the micro and macrovascular complications, namely retinopathy, nephropathy, neuropathy, which are the microvascular. Macrovascular, stroke, heart attack, and peripheral vascular disease. But macrovascular complications is not under the control of the treating doctor. It is under the control of metabolic syndrome. So diabetes, pre-diabetes, metabolic syndrome, these are all closely linked channels. And another thing that we can define hypoglycemia is, earlier there was just type 1 and type 2 diabetes. According to the latest classification of American Diabetes Association, there are 7 different types of diabetes. I would define it as a variable combination between the autoimmune activity against the beta cells of the pancreas and insulin resistance. And insulin resistance is contributed by metabolic syndrome. So either earlier it was just type 1 diabetes, which tells that there is autoimmune activity against pancreas. That's it. And type 2, insulin resistance. But now there are different types of diabetes. There can be actually a variable combination. Something can look like type 2, but it actually has components of type 1, and something can look like type 2. So there's that I'll be telling further how we further classify diabetes. There are the newly proposed classification. According to that, you have type 1, type 1.5A, which is called ketone-prone diabetes, type 1.5B, which is called latent autoimmune diabetes in adult, type 2, type 3A, type 3C, type 3D, and type 4. That's the latest accepted classification.
Dr. Anna, eye is a very important organ which is going to manifest the diabetic changes, right? So what are the various parts of the eye that can be affected by diabetes? Yeah.
Almost all part of the eye can be affected by diabetes, starting from the lids. The usual common swellings like odeolum, chalazion, they are more common in diabetes when there is deranged blood sugars. And if you look at the cornea, because of decreased sensation which occurs as part of diabetic neuropathy, there could be neurotrophic cornea or neurotrophic ulcers which develop. Later on it can cause infective keratopathies as well. Then looking at the lens, we all know the cataract is common in elderly population, but in diabetes it can occur at a younger age. And there is a typical type of cataract called snowflake cataract. And another common complaint which patients comes with is change in vision which occurs with derangement with the blood sugars, that so that the prescription of the glasses can change. That can happen with hyperglycemia and hypoglycemia. Then primary open angle glaucoma, diabetes is a risk factor. And if you go more posteriorly, the retina, the most common cause for the decreased vision, diabetic retinopathy, which is very common cause, and that is there in the diabetes mellitus. And the optic nerve, there is a condition called diabetic papillopathy, which causes decreased vision, and when you look at the disc look edematous. And also these are all due to some occlusions of the blood vessels of the optic nerve. There is a bit more severe form of diabetic papillopathy called non-arthritic anterior ischemic optic neuropathy that can also occur with diabetes. Then the cranial neuropathies which occurs with diabetes, it can affect the 3rd, 4th and the 6th cranial nerve. So there will be extraocular muscle palsies and the patient present with diplopia. Typically in this diabetic 3rd nerve palsy, it is pupil sparing 3rd nerve palsy which occurs. And another thing which you should all be aware about is the mucormycosis which can occur in the orbit, especially in uncontrolled diabetes. So that should always be borne in mind when we are seeing a patient with uncontrolled diabetes who present with orbital cellulitis. So these are the various manifestations.
Just continuing with that, if you can enlighten us regarding the pathogenesis of various changes in eyes due to diabetes, especially with focus to diabetic retinopathy and macular edema.
Yes, sir. Mainly in diabetic retinopathy, it's a microangiopathy. It's mainly affecting the capillaries, the precapillary arterioles, and the postcapillary venules, even though other vessels are also involved. So, what is the mainly happening is microvascular occlusions and increased vascular permeability. So, in the capillaries, there is this loss of the pericytes and basement membrane thickening, endothelial proliferation, and damage, which actually cause some outpouchings from the capillaries. These are called microaneurysms. From the microaneurysm, the plasma constituents can leak into the retina that cause macular edema. That is, this leak, if it is in the macula, that cause macular edema. It is one of the most common cause of decreased vision in diabetic retinopathy. And the vessels are also damaged, so there could be diffuse leak from these vessels. These are all causing macular edema part. Then along with these vessel changes, hematological changes like increased rouleau formation, platelet aggregation, all these occur, and these all lead to decreased oxygen transport to the retina and retinal ischemia. So when the retinal ischemia occurs, there is release of growth factors. These growth factors like vascular endothelial growth factors, and that would stimulate the retina to produce new blood vessels. These new blood vessels can either occur on the disc, that is optic nerve disc, or it can occur in any part of the retina. The problem with these vessels is that they can bleed easily, which can cause either a vitreous hemorrhage, that is hemorrhage into the vitreous, or it can cause a traction retinal detachment, and that can cause sudden decrease in vision in these diabetic patients. So the main two pathogenesis, that is causes, are this microvascular occlusion and vascular permeability.
And Dr. Sumitra, if you can explain us regarding the structure of the insulin molecule, that will kind of help us to take the discussion forward.
So now insulin has, it's a polypeptide. It's a polypeptide chain. It has two chains, A chain and B chain. A chain is also known as the glycine chain, and B chain is called the phenylalanine chain. Now these two chains are held together by disulfide bonds. We have inter-chain disulfide bond and intra-chain disulfide bonds. The inter-chain disulfide bonds are between the A chain and B chains, between the cysteine residues. 7 cysteine residue of A chain and 7 cysteine residue of B chain. Likewise, we have intra-chain cysteine disulfide bonds between the 6th and 11th cysteine residues of the A chain. So that was about the structure of insulin molecule. Now, insulin is not released as mature insulin; it is released as pre-proinsulin. That is this is a premature form where initially 23 amino acids are removed from this pre-proinsulin, and then we get another form from which again a protease will cleave this insulin to give you the mature insulin. So during that cleavage, there's removal of that C peptide. Now C peptide is also released into the circulation, and it is generally used as a measure of insulin secretion because the degradation of C peptide is much lower than that of insulin, and also it's very we use it as a routine measure along with insulin. C peptide is also measured. The rate of secretion is more constant.
Dr. Sujama, so is there any role for adipose tissue in the glucose metabolism and homeostasis?
Yeah, now the role of adipose tissue in glucose metabolism is coming up more and more. Initially, it was thought that, the excess glucose that is released from the liver is stored in the adipose tissue by converting it more into fat. So unlike in other tissues like skeletal muscle where most of the glucose is converted to glycogen, in the adipose tissue under the influence of insulin, most of the glucose gets converted into fat. And also you have an enzyme, hormone sensitive lipase, which is inhibited by insulin. So that insulin promotes lipogenesis, so it inhibits lipolysis. So when hormone sensitive lipase is inhibited, the breakdown of fat in the adipose tissue is inhibited. You also have another enzyme, lipoprotein lipase, in the endothelial wall, which is stimulated by insulin. So it helps to break down the circulatory fats, triglycerides, to fatty acids and glycerol, and this is then taken into the adipose tissue where it is again synthesized to triglycerides and stored. Now, apart from these functions, adipose tissues also release certain hormones like adiponectin, leptin, which are found to have a anti-hyperglycemic effect. That is, they have a role in bringing down the blood glucose level, not directly, but they are thought to increase the sensitivity of tissues to insulin, which will facilitate the entry of glucose into the tissues. And some articles also say that they help to break down the lipid stored in the tissue so that they can reduce the fat storage, which is thought to be one of the factors contributing to the non-sensitivity of tissues to insulin. So this is the beginning stage. So mainly it is the role of leptin and adiponectin that has been discussed.
Anup, question to you. Just a minute. How do you manage a patient, diabetic patient in the OPD? If you can just elaborate on the common clinical features and the basic workup, and also how different is it from an inpatient management? And when do you really consider starting insulin?
The moment, this is a very common thing known to everybody. But just when a patient walks into the OPD, the symptoms that a patient complains to you, as classically described in the textbook, it's polyuria, polydipsia, and polyphagia. And for this, whenever a patient walks in, they can also complain of excessive fatigue. And because diabetes is, as I earlier told you, characterized by absolute or relative insulinopenia, there will be a lot of fat breakdown and protein breakdown. So they might even tell you about a significant weight loss. So actually, there's a little counterintuitive. BMI would be low, but BMI, like in cirrhosis patients, is not applicable here because of the significant muscle and the fat loss. So I always give this example whenever you have a solution with increased solutes. We can correct the osmolality by adding more water. Similarly, if you look at the formula of serum osmolality, it's 2 into sodium plus blood glucose by 18 plus blood urea nitrogen by 2.8 or blood urea by 6. So I would be thinking, why am I telling the formula of serum osmolality? Just to say that sodium is 18 times more powerful than glucose. So glucose in general, you can say it's not an effective solute, but in diabetes, it starts behaving like an effective solute, and it will cause a lot of osmotic diuresis. So there will be a lot of water going in the urine. So as you can imagine, when water is going in the urine, the serum osmolality will rise and that is detected by the osmoregulatory center, which is in the hypothalamus, which will release ADH, and ADH expressing aquaporin 2 receptors, just like we pouring water into the solution. Also, the thirst center is also in the regulated by the osmoregulatory center, so you drink water. So polyuria is explained, polydipsia is explained. Similarly, the products of catabolism activate the hunger centers, and that is the reason for polyphagia. So the classical presenting symptoms are always polyuria, polydipsia, polyphagia, associated with fatigue and weight loss. Also, you can extrapolate. Also, when the patient complains of this symptom, if you want to diagnose diabetes, now it is an era where blood investigations have gone beyond the clinical diagnosis to make a mark. So basically, you can define diabetes and pre-diabetes from fasting blood sugar, postprandial blood sugar, random blood sugar, and HbA1c. So you can diagnose diabetes anything or. If it's a fasting blood sugar of more than 126 milligram per deciliter, postprandial blood sugar or postprandial blood sugar more than 200 milligram per deciliter, random blood sugar of more than 200 milligram per deciliter in the presence of osmotic symptoms, which I just described, or HbA1c more than 6.5. And when coming to the pre-diabetic range, HbA1c between 5.7 and 6.4 is pre-diabetic for the HbA1c. For fasting blood sugar between 101 to 126. No particular value for random blood sugar in the pre-diabetic range. Postprandial blood sugar of more than 141 to 200. So patients at home itself, if they see these symptoms, if they have a glucometer, 2 hours after taking. So postprandial is definitely, that is one point to be remembered. That is after food, there's no reference values for 1.5 hours or 1 hour 45 minutes. So after 2 hours, you look the blood sugar. If it is in the pre-diabetic range or in the diabetic range, that itself you can make a diagnosis of diabetes. Continuous ambulatory blood sugar monitoring is the gold standard, but because it is expensive and not routinely available, for now, even though all these are used, HbA1c is the gold standard that we use for diagnosis. And coming to that, there are certain clinical conditions where you can have falsely elevated HbA1c as well as falsely low HbA1c. So falsely elevated HbA1c, you can have it in iron deficiency anemia, and falsely low HbA1c, you can have it in liver disease and hemolytic anemia, bone marrow infiltration syndromes, and things like that. So all these need to be considered. So the clinical scenario and this thing. And one more additional point I would like to add from a clinical perspective. Whenever a patient is diagnosed with diabetes, I would like to look at his blood vessels first, because the only time period that we have with us is the first 5 years. And that is the first 5 years of diagnosis, not when we diagnose, when the patient actually has diabetes. So sometimes the patient might be so what literature says is the first 5 years of sugar control will help us to control the microvascular complications. No effect on macrovascular complications. Macrovascular complications is under the control of metabolic syndrome. And metabolic syndrome, I'd just like to elaborate. According to the WHO guidelines, it is 3 out of 5. That is waist circumference of more than 102 centimeters in males, more than 88 centimeter in female. When converted to Indian standards, more than 90 centimeter in male, more than 80 centimeter in female. BP more than 130, 85. Fasting blood sugar of more than 100, which corresponds to HbA1c of more than 5.7, HDL of less than 40 in males, less than 15 females, and triglyceride of more than 150. If you have 3 out of 5, you have metabolic syndrome. So as you can see, pre-diabetes is what is defining metabolic syndrome. And so you should actually start treating the patient even before, even this thing. And also another important test that we have to do is urine for microalbumin, because diabetic nephropathy, the moment most of the patients who come to us are detected in stage 4, when the creatinine has actually elevated, 50% of the glomerulus will have already been damaged by the time creatinine is elevated. Urine albumin creatinine ratio. Protein excretion of 30 to 300 milligram per day or 20 to 200 micrograms per minute is microalbuminuria. It can be detected by this dipstick test, which is urine albumin creatinine ratio. So for the diabetic nephropathy, which is basically fibrosis of the kidney, the chemical that causes it is transforming growth factor beta, and the earliest stage which is practically detectable is stage of microalbuminuria. Along with that, hypertension will also be there because of lots of physiological mechanisms. I also sending to the ophthalmologist to look for various grades of retinopathy and all that. So microvascular complications is what we have under control. And whether to start OHA or insulin, guidelines say HbA1c of between 7 and 9 without micro or macrovascular complications. You can use OHAs, and that too in a particular order. Metformin is the first line, SGLT2 inhibitors are also first line, GLP-1 analogs. These are the combination that we use. And if it is with micro or macrovascular complication, they advise insulin. HbA1c of more than 9 with or without microvascular complications or macrovascular complications, insulin is what is defined. But because of practical difficulties, we decide, so some patients may not want to start insulin. So we do an alteration, because this is the gold standard. Many of the times it may not be possible, but this is what American Diabetes Association has to say as per the latest guidelines.
You did mention about the diabetic retinopathy part also, Doctor, and if you can just tell us more about the diabetic retinopathy part.
Diabetic retinopathy, the symptoms and signs wise, a lot of patients may not have any symptoms at all. So they have to be regularly screened. Depending upon the staging of diabetic retinopathy, it varies. So the diabetic retinopathy can be staged or graded broadly into a non-proliferative diabetic retinopathy and a proliferative diabetic retinopathy with or without maculopathy. So non-proliferative diabetic retinopathy without any proliferative changes. So proliferative changes are the new vessels which I have mentioned before on the retina, either on the disc or on the elsewhere in the retina. So non-proliferative diabetic retinopathy, according to the severity, they are divided. There are different classification methods. The commonly used that we do in the clinic is International Clinical Disease Severity Score. ETDRS is the one which is routinely heard of, but it is a bit more detailed and it's used for research purposes. So according to international classification, no DR, mild, moderate, severe, and proliferative diabetic retinopathy. Mild means at least there should be one microaneurysms. So one microaneurysm is the earliest change happening. So any signs more than that will go into moderate. So moderate is more than mild, less than severe. So other changes that can occur in moderate are dot and blot hemorrhages, which occurs in the middle layers of the retina, cotton wool spots, then which is occlusion of pre-capillary arterioles. Then there could be hard exudates, which are the lipids and the proteins which are depositing as part of the macular edema. Retinal thickening, that is actually the edema. Then vascular changes like venous bleeding, IRMAs, intraretinal microvascular anomalies. So for calling it, that is a moderate. To call severe, there should be at least one of the three manifestations which I'll describe now. It's called 4:2:1 rule. That is hemorrhages, dot and blot hemorrhages in 4 quadrants, venous bleeding in at least 2 quadrants, and IRMA in 1 quadrant. If any of the 3 is there, it will be severe. Okay. Proliferative means if any proliferative stages are there, like features are there, like new vessels on the disc or new vessels elsewhere, or if the patient is having a vitreous hemorrhage or a hemorrhage on the retina called pre-retinal hemorrhage or a tractional retinal detachment, These all can go into proliferative diabetic retinopathy. Even in advanced stages, sometimes these new vessels will grow on the iris or on the ankle and can result in neovascular glaucoma. But then if there is macular edema or not, that is another classification. Any of the stages will have macular edema present or not. So according to international classification, either diabetic macular edema is present or is absent. That is, if there is retinal thickening or hard exudates at the macula, it is present. If it is not there, it's absent. And it's grading mild, moderate, severe, depending upon how severe it is. So how close it is coming to the fovea. So if it is well away from the fovea, it is mild. If it is at the fovea, it is severe. So that is a classification.
Okay. Since we are done with the classification, can you tell us something more about the management of both
sure.
NPDR and PDR?
Again, here it depends upon the severity. The management depends upon the severity of the diabetic retinopathy. Definitely, it has to be co-managed with other systemic treatment. Everything has to be done, which will gives our treatment more effective. So the non-proliferative diabetic retinopathy treatment depends upon whether there is diabetic macular edema or not. So otherwise, if there is no diabetic macular edema, we would follow up the patient, the no diabetic retinopathy and mild one every year, moderate one every 6 months, and severe 4 months. But if there is diabetic macular edema which is affecting the vision, and depending upon how much it is there are different modalities of treatment. Presently, we have intravitreal injections. We give either anti-VEGF or steroids. Anti-VEGFs, the commonly used are ranibizumab, bevacizumab or aflibercept. Then steroids, ozurdex implant, which is dexamethasone implant, which is given monthly depending upon the response. Then we have lasers for the macular edema, which is focal laser to the microaneurysm to prevent leakage. That's regarding the macular edema part. Regarding the proliferative stage, so once they are going to proliferative stage, they has to be treated even though there is no macular edema. So what we are aiming is to regress the new vessels. For that, pan-retinal photocoagulation. That is, laser is applied to the extramacular area. We're not applying to the macula, the rest of the retina, so that the new vessels will regress. The principle is, when we are giving lasers, the ischemic retina is converted into anoxic retina and the VEGF drive is reduced so that the new vessels will regress. Then depending upon the complication, if there was a vitreous hemorrhage or a traction retinal detachment, the patient should go for a vitrectomy. That is surgery where we remove the, go into the vitreous and take out the blood. That is, if it is neovascular glaucoma, the glaucoma management should be done.
Thank you. Dr. Suja, we did mention about the role of adipose tissue in the glucose hemostasis and metabolism. Likewise, there is a role for gut also. So can you tell something more about that?
Yeah, so in a normal individual, in the fasting state, that means when there is blood glucose level is not high. So in the fasting state, we all know the blood glucose is maintained within the normal range by various regulatory mechanisms. But in the fed state, you have influx of glucose coming from the GI tract. And one of the main factors that regulate or control this influx of glucose into the circulation from the GI tract is the gastric emptying time. So the time or the rate at which the contents from the stomach is emptied into the small intestine. So that is one of the key factors that are found to play a role in regulating the blood glucose level.
Okay.
So now the factors that influence the gastric emptying time are varied. One of them is the consistency of the food. So solid foods take more time, whereas liquid foods empty faster. And the type of food content, like fat, takes more time for gastric emptying, whereas proteins and carbohydrates empty faster. And there's also influence of hormones, and surprisingly, insulin and glucagon are not found to have any role in this gastric emptying, but other hormones secreted from the pancreas, from the pancreatic beta cells, amylin. Then you have pancreatic polypeptide. All these inhibit gastric emptying. So they slow down the emptying of contents and then further its absorption into the circulation. You have cholecystokinin, which also inhibits. There are two other hormones, GLP-1 and gastrin inhibitory polypeptide or glucose-dependent insulinotropic polypeptide. These two are also found to inhibit the gastric emptying. So that's one factor where gastric emptying is one role of GIT in controlling the blood glucose level. The other important factor is what we call as an incretin effect, where where this effect is based on our observation that following an oral injection of glucose, you have an increased insulin response compared to glucose which is given intravenously. Right. And this is found to be because of release of hormones from the intestine like GIP and GLP-1, which are found to stimulate insulin secretion from the pancreatic beta cells. So these are the roles of, these are the two main factors that are found to be involved in glucose homeostasis.
Okay, thank you. To Dr. Sumitra, can you explain the biochemical basis of insulin's interaction with its receptors?
So, the insulin receptors, they have two subunits, two alpha subunit and two beta subunits. The alpha subunits are located extracellularly, to which insulin binds, and beta subunits are located intracellularly, which has tyrosine kinase activity. Okay. So when insulin binds to this alpha subunit, there will be phosphorylation, or the tyrosine kinase will be activated, and there will be phosphorylation of the beta subunit. This will phosphorylate the insulin receptor substrates, resulting in a series of signaling processes. The end result of all these signaling processes are translocation of the GLUT4 receptors, GLUT4 transporters to the plasma membrane, influx of glucose, glycolysis, glycogen synthesis, and fatty acid synthesis. So in diabetes, all these signaling processes are altered so that this glycolysis and further activities will not happen.
Right. To Anup. Anup, can you just explain us the key management principles of both diabetic ketoacidosis and HHS?
So before going straight away into diabetic ketoacidosis, I would like to shed some insight because those investigations are available in our hospital right now. So as I told you earlier, it's a variable combination between autoimmune activity and against the beta cells of the pancreas. And there are certain types of diabetes like latent autoimmune diabetes in adult, which can look to you like a type 2. Because generally there is a saying among the population, yeah, you had diabetes at 40 years, so definitely it will be a type 2, it will be a safer type of diabetes. But these people actually have a significant autoimmune activity against the pancreas. They just go into macro and macrovascular complications so fast. And usually once they go into those kind of complications, we can just see them going into these complications and just see them suffer, just like how I told you for nephropathy. So, actually, just like what Madam said, glucagon and somatostatin are supposed to be counter-regulatory hormones. So they are supposed to inhibit insulin, but it's not actually so. Glucagon actually stimulates insulin release, but it stimulates somatostatin much more than the insulin. It's the somatostatin which inhibits the insulin ultimately. So we have something which is called, so when a patient walks into, you want to know whether the significant autoimmune component is there. So just like how Madam had told you, that secretory vesicles, three things are released: one insulin, one C-peptide, and pancreatic polypeptide. So C-peptide has a half-life of 30 minutes. Insulin has a half-life of only 3 minutes. So we use fasting C-peptide levels to diagnose whether actually the beta cells are secreting enough insulin. So the normal amount of this thing, if you say it in nanomoles per liter, is 0.3 to 0.6 nanomoles per liter. You convert it into a nanogram per ml, just multiply it by 3. So it is up till 1.8 nanogram. So basically, you do, if you are suspecting autoimmune activity, you look for the fasting C-peptide levels. If it is less than 0.3, you actually give glucagon to stimulate the beta cells. So you give 1 mg glucagon. It's called glucagon stimulation test. And even after that, if the the fasting C-peptide, which is the analog of insulin, is less than 0.3, then we come to a diagnosis that we come to a possibility that probably there's a significant autoimmune activity. And then to confirm that, we have to do certain antibodies, just like how we do in Hashimoto's thyroiditis. There are 4 antibodies that are done: anti-GAD antibody, which is anti-glutamate decarboxylate, anti-zinc transporterate, anti-islet cell antibody, and anti-insulin antibody, out of which the one for latent autoimmune diabetes, the most important one is it is done here, anti-glutamate decarboxylase. So whether to start insulin or not. So if you see a patient who are having a significant autoimmune activity or reduced insulin secretion, you cannot wait until the patient reaches. He will reach there in no time. So you have to immediately initiate the patient on insulin. So what the American Diabetes Association says is 40 units is the amount of insulin that's secreted from the pancreas. The ideal dosaging is regular insulin, short-acting insulin, or its counterparts like Novorapid or all those. You give it at 4 a.m., 1 p.m., 7 p.m. 3 doses, 8, 8, 8 each, and then 16 at night. And one common problem that I have encountered in OPD is a diabetic patient is coming to you, whether it's insulin or OHA. We cannot increase insulin we increase like some 4 units. The patient comes back with the same HbA1c all the time. They might go into some hypoglycemic episode. They might, reduce back to the insulin. So American Diabetes Association has told about treatment targets. So it's like conducting class tests for students. Less than 180 after food and 80 to 130 fasting. So what I ask my patients to do is 2 blood sugar values every day so that it's not increase in number, that it is affordable. 1 fasting, 1 post breakfast the first day, second day 1 fasting, 1 post lunch, third day 1 fasting post dinner. And to increase the insulin that they are taking by 4 units, if it is above that treatment target, and reduce it by 2 units. And also tell them about the hypoglycemia. Even if we have such daily strict control, you can definitely achieve the HbA1c. Still, because of Down's phenomenon, Somiyaji phenomenon, there is a chance of patient going into hypoglycemia. So you tell the patients about the symptoms of hypoglycemia. You have increased heart rate, sweating, and increased craving for food. If you see those symptoms, please check the blood sugar. And sometimes what can happen is patient can be detected in the neurological symptoms. So what can be done at home is you can have honey, and you can smear it in the oral mucosa, because if you give any kind of a solid or liquid, they will aspirate and come with an aspiration pneumonia. So drug treatment, as I told you, based on HbA1c targets and the first line drugs, whatever, metformin, SGLT2 inhibitors, GLP-1 analogs. So as madam said, these GLP-1 analogs and DPP-4 inhibitors are based on your incretin effect. It was seen that these hormones, GLP and GIP, will stimulate the beta cells of the pancreas to secrete insulin. So there are 2 ways in which the disadvantage that these hormones had is they were disintegrated fast by dipeptidyl peptidase 4. So one thing is GLP-1 analog, which counteracted this disadvantage of low half-life by combining it with the protein. We have a very good drug, semaglutide, which is still used in the trials for fatty liver as well as for this thing. And DPP-4 inhibitors, which are your gliptins, which is sitagliptin, linagliptin, and all that. And SGLT2 inhibitors, especially with other comorbidities, because it has got a significant propensity for reducing edema. It is again one of the first drugs. Your dapagliflozin is there, empagliflozin is there. Now again coming to the complications of diabetes, the metabolic complications, diabetic ketoacidosis. So there are 2 components. One is diabetic ketoacidosis. Next is hyperglycemic hyperosmolar state, which was used to be called as HONC before. Now the term is that. Now, the essential difference is definitely it is an augmented part of diabetes. So insulinopenia is definitely there. But diabetic ketoacidosis, the difference between that and hyperglycemic state is in the amount of counter-regulatory hormone. First of all, there are a lot of people who think that uncontrolled blood sugars with urine ketones positive is diabetic ketoacidosis. That is not the state. Diabetic ketoacidosis always has to have a precipitating factor. Usually it is infection, inadequate insulin, infarction, which can be MI or stroke, pregnancy, and cocaine. Some precipitating factor has to be there. And it is characterized by the clinical syndrome of nausea, abdominal pain, acidotic breathing, and lethargy. Patient will also have low BP, high heart rate, and high respiratory rate, very easily explained from physiology. When you have a lot of osmotic diuresis that is happening because of fluid loss, you have low BP. And why the acid formation happens, that is the classical pathophysiology. So as I told you, fatty acyl coenzyme is circulating in the cytoplasm and it is causing insulin resistance. Now when you have this counter-regulatory hormone excess, which is specific characteristic of diabetic ketoacidosis, there is expression of an enzyme called carnitine palmitoyl transferase in the liver that will pull the fatty acyl coenzyme into the mitochondria. It will get converted into HMG coenzyme, beta hydroxybutyrate, acetoacetate, and acetone. And it is this acetoacetate and acetone. Many times in the ER, there will be people who are respiring at 40 per minute. Why do we intubate those patients? That is because we are not conditioned to respire at that high rate. After some time, definitely we undergo respiratory muscle fatigue and this thing. So basically, when a patient has the high respiratory rate, the patient is trying to throw out the acid in the form of carbon dioxide. And in the ABG, if you take, you will find a high anion gap metabolic acidosis. That is, the anion gap will be more than 12. So these are the classical clinical presentations. So the characteristics characteristic feature in diabetic ketoacidosis is fluid deficit. Because the insulinopenia is so high, so much of osmotic diuresis is there. Almost 9 liters of fluid deficit is there. We have to correct that at a particular rate. 3 liters of fluid in the first 3 hours, 3 liters in the next 6 hours, and last 3 liters in 12 hours. That is how we rate a fluid correction. As soon as we start fluid correction also, we have to bring down the sugar levels by giving IV insulin. IV insulin is given at an insulin infusion rate at 0.15 unit per kilogram stat and 0.10 unit per kilogram per hour. Okay, so here in other places where you do not have the luxury of Amrita, like an infusion pump and all that, you can add like 25 units in 500 ml normal saline and run it at 100 ml per hour. So 5 units per hour for 5 hours, 3 units per hour for the next 5 hours, and 1 unit per hour for the next one. Infusion pump, it is easy, 40 by 40, you give it like that. So insulin correction. Another important point is regarding physiology. When you give so much of insulin, potassium will be pushed into the cell. So stroke can precipitate diabetic ketoacidosis. Sometimes treatment of diabetic ketoacidosis can result in a bilateral lower limb weakness, which is one of the classical manifestations of hypokalemia. So 20 milliequivalents will correct the potassium by 0.25. For every alternate pint of fluid that you are giving, the liters, you give 20 milliequivalents of potassium chloride, and you keep on monitoring the potassium values. So this is in when coming to the hyperglycemic state. It is a severe insulinopenia. There will be some precipitating factors, and it's usually an old patient that usually comes to. So they do not have that much of a counter-regulatory. So they don't have acidosis also because of the mechanisms that I told you. So hyperglycemic, hyperketonic state, it's again managed with fluids and insulin. But there are certain classical differences between the both. That is what I told.
Just to add on to what he told about diabetic ketoacidosis, one thing is that if the potassium is too low, you usually don't start the insulin infusion. You correct the potassium to a certain level before you start the insulin infusion also. And when do you really stop the insulin infusion? How do you convert insulin infusion to like the bolus doses of insulin, if you can just... Yeah.
So once you start the insulin and you see that the sugars have come down below 200, you can switch to the same dose that I told you, 40 units of insulin from pancreas. You can shift to 888 regular insulin and then 16 of basal bolus, which is Lantus, which is given every night, or Degludec on alternate. This is the standard regimen that followed. But depending, so there are different types of insulin and duration of action. So as at least until the patient is treated. And as I told you, we have to treat the precipitating factor also. What if the patient is having an infection? You have to definitely give an antibiotic and other things. And just like what madam was saying, there are certain diseases that are unique to diabetes. So diabetic ketoacidosis, if a patient is prone to developing such a metabolic complication because of diabetes, they usually have certain infections which are seen in diabetes. They're called diabetic defining diseases, like you have HIV defining disease. These are, one of them is rhinocerebral mucormycosis, which was a great news during the COVID time. It was black fungus. It was actually related not to COVID but to the steroid that we give during COVID. Malignant otitis externa, emphysematous cholecystitis, emphysematous pyelonephritis, and some literature also say melioidosis has got a very strong association with uncontrolled diabetes.
I think with that we have reached the end of our pre-planned questions, but the last round, if you can just tell the students like what are the questions to expect from this topic, starting with Dr. Raina.
Very common question that comes is the signs of diabetic retinopathy, where you should be able to mention about the different retinal manifestations like microaneurysm, dot plot hemorrhages, and other manifestations. Then staging of diabetic retinopathy. Then one mark question, it can come like what is a typical cataract which can occur with diabetes.
Dr. Suja?
So I think one aspect which we didn't discuss here was actions of insulin, but
please.
it's a common question that is asked in the UG question paper. So actions of insulin, mechanism of secretion of insulin, and you can also get a physiological basis questions like reason for polyuria, polyphagia, polydipsia. So these are the common questions.
If you
that we
can't, if you want to elaborate on that, please do. Or,
I think sir had okay
Yeah.
yeah. So polyuria is mainly because of osmotic diuresis, because of presence of glucose in urine. So when the renal threshold is exceeded, like 180, when the glucose level goes above 180 milligram per deciliter, glucose starts getting excreted in urine, and because of its osmotic effect, it draws water from the tubular epithelial cells, and that results in osmotic diuresis, and which we call as polyuria. Polydipsia is again because of loss of water. The thirst centers are stimulated, which results in thirst mechanism, and that is what results in polydipsia. Polyphagia is because of in the hypothalamus you have two centers, feeding center and a satiety center. And normally the feeding center is kept inhibited by the satiety center, but in diabetes mellitus, because of lack of entry of glucose into the satiety center, the satiety center is not able to function properly, which is to inhibit the feeding center. So the feeding center becomes overactive. That's a reason for polyphagia. So these are the few questions that you get.
right. Dr. Sumitra, if you have missed anything, please feel free to add that.
So normally we ask an essay question from this section, where a clinical case will be given, a simple case, and the students will be asked to diagnose the case. It will be easy for them because all the typical presentations would be given. And then the next sub-question would be to describe the regulation of blood glucose, how the blood glucose is regulated in the body. And then questions like what is the significance of estimating glycated hemoglobin in patients. Then enumerate the complications of diabetes mellitus. These are the commonly asked questions.
Thank you. Anup?
Everything what we have discussed here can be a part of. So first is how you diagnose diabetes on a clinical basis, and to connect it with the physiology of why it happens, and what are the blood parameters that will tell you that the patient is diabetic or pre-diabetic. Then definitely question on metabolic syndrome, because it is closely related to fatty liver and macrovascular complications. Diabetic ketoacidosis definitely is a very important question, essay question. You can have it as a clinical scenario based on the new CBME, or you can just have it as a straightforward question as describe the clinical manifestations and things like that. Questions separately on the topics discussed here: retinopathy, nephropathy, neuropathy. Nephropathy, especially the pathological aspects. What are the lesions that are seen in diabetic nephropathy stage 3A, stage 3B? How do we clinically diagnose? Both are different. As I told you, initially there's a stage of hyperfiltration which cannot be detected. Stage 2 of diabetic nephropathy, it's actually not practical to detect because there is a lack of nocturnal dipping of BP, which normally occurs, and that nobody can practically detect that. Stage of microalbuminuria is the stage where we can, what is microalbuminuria, quantify it, and what is before we needed to do 24-hour urine albumin, now we can do albumin creatinine ratio. And definitely when the answer that is expected from a student is whether the student has that flavor. By the time the patient has reached diabetic nephropathy stage 4, there are so many things that you can say, but there is nothing that there is a decline. What is the rate of decline of GFR? And have a patient coming to you, clinical scenario example, patient is coming to you with increased creatinine. He's been a diabetic for so many times. How can you say, do you need to do a renal biopsy to say that the patient is having diabetic nephropathy? Or in other words, what are the things that will say that the patient has diabetic nephropathy without doing a biopsy? Presence of retinopathy, presence of hypertension, presence of microalbuminuria, absence of nephrotic range proteinuria and microhematuria, presence of pedal edema. These things, even without a biopsy, if all these things are there, you can say that the patient is having diabetic nephropathy. Rate of decline of GFR is 8 to 10 milliliter per a minute per year. So that is, if a patient's creatinine is 1.5, GFR maybe roughly around 45. In 3 years, he'll become dialysis dependent. So whether you have to take him up for a transplant, that decision has to be made at that point. So those will be the clinical angles in which the questions can be asked.
Okay. Thank you, Anup. Thank you all. I'm sure that was a very informative kind of session for the students. See you for the next session. Thank you.
Thank you.